This web-based video was designed and developed by Drs. Kim Poulsen, Jim Phillips, Tom Sowa, and Irene Damazzi. Its purpose is twofold. First, to serve as a clinical tool to supplement both the fundamental didactic knowledge and requisite skills previously learned for the human shoulder complex, and second, to facilitate direct application of this knowledge and skill to enhance performance in the clinical setting. In a logical and clinically based approach, Dr. Poulsen and Dr. Phillips provide an integrated examination including special tests for common shoulder pathologies frequently seen in clinical practice. These pathologies include shoulder impingement, shoulder hypermobility, and degenerative shoulder conditions. Normal shoulder examination serves as the reference for this patient-client management approach.
Observation of the patient starts when he is walking into the clinic. Posture, movement preferences, guarding, and quality of movements are assessed. The observation continues during the intake, which is followed by a closer inspection and examination procedures. The inspection seeks to gather information about symmetry, alignment of head, body, and extremities, tissue volume, bony alignment, skin integrity, and scars and skin coloration. Notice bony alignment as clavicular height and angulation, acromion process location, prominence of muscles, volume, for example, trapezius, deltoid, and pectoralis muscle. Notice shoulder position, head positioning, soft tissue volume, general posture, including thoracic and lumbar spine curvature. Notice head positioning including tilting, shoulder height, scapular distance from spine, tilting or angulation of scapula, and spine alignment including signs of scoliosis. Functional test seeks to determine the quality of motion, neuromuscular control, available range of motion, ability to complete a task, and comfort or pain associated with the task. Always test the non-involved side first. During reach to neck, notice any signs of impingement or compensatory motion. During reaching to the back, notice the height of the thumb in relation to the spinal segment. C7 is a good landmark, or if there's any scapular winging. During reach to the opposite shoulder, notice any signs of impingement and notice the distance of the reach. In this procedure, AC joint compression test can be performed. Assessing gross strength in the hand, you can consider a JMR testing as well. During the push-pull, you will test growth strength and the ability to stabilize the shoulder. Active range of motion seeks to assess the patient's ability to move the extremity against gravity. Always start with the non-involved extremity first before testing the involved side. Notice pain, symmetry, and compensatory movements. Consider measure the movement first visually and second with a goniometer. Notice the excursion of the movement, compensation and tolerance during the flexion. Examine the scapulothoracic rhythm and any signs of impingement that often can result in a compensatory movement strategy. Notice excursion and scapulothoracic rhythm in the posterior view assessing abduction. Notice compensatory motions as early scapular motion and end position of the inferior angle of scapula. The distance from the thoracic spine to the inferior angle of the scapula could be measured. During flexion seen from the side, measure excursion in a thumbs-up position to avoid impingement. Maintain the fulcrum for measurement by estimating location of the greater tubercle that will move significantly during this motion. In abduction, measure the excursion and notice any signs of impingement. Notice compensatory motions as the shoulder hikes or there's trunk lean. In the seated position, external rotation can be measured. This is considered a modified version of external rotation. Make sure elbow is kept close to the trunk and notice any signs of apprehension at the end range. During measurements for external rotation, notice the roll under the humerus, that is to maintain the glenohumeral joint in a neutral position, avoiding an anterior displacement. Examining end feel also is best appreciated in this position without a possible anterior subluxation of the humerus. Be aware of tolerance at the end range. During internal rotation in supine, the passive range of motion is followed by a goniometric measurement. During forward flexion in supine, one may have the patient at the upper end of the table to appreciate all available motion, or consider doing it with the patient in a seated position. During abduction, scapula is not stabilized. Notice available range of motion and impingement signs as well as apprehension. The fulcrum is the acromioclavicular joint. abduction with the scapula stabilized. Stabilize scapula on the thorax and appreciate the motion of the glenohumeral joint. Next follows the goniometric measurement with and without the scapula stabilized. During measurements of extension prone, do active range of motion first, then passive range to assess end feel. Appreciate the end feel by stabilizing the scapula on the thorax. Next, use the goniometer for a goniometric measurement. Muscle length testing of the bicep. The fulcrum is the lateral epicondyle and the stationary arm goes on the humerus midline. First, maximize the extension of the shoulder. Second, maximize extension of the elbow. Consider doing a trial without the goniometer first. Then read the goniometer at the end position. This is the positional measure for the length of the bicep. For muscle length testing of the tricep, the fulcrum is the lateral epicondyle. The stationary arm of the goniometer is on humerus midline and the moving arm is in the midline of the forearm. First step is to maximize flexion of the shoulder. Second is flexion of the elbow. Then the goniometer is read at this end position. For both muscle tests, notice that you maximize the proximal joint first, followed by the distal joint. Also notice that the measurement is an elbow joint positional measure expressed in how many degrees are present in elbow flexion at the end position. For muscle strength testing MMT, always first do active motions against gravity. For upper trapezius, place bilateral resistance to both shoulders during shrugging. During forward flexion, start with active movement on the uninvolved side before progressing to the involved side. Stabilize scapula. Notice resistance at the distal humerus. During measurements of prone extension, stabilize on the trunk. During horizontal abduction, notice the head positioning is away from the upper extremity to be tested. Stabilize the opposite scapula on the thorax. Resistance is in the direction of the elbow. For scapular adduction with depression, testing the lower trapezius, stabilize the opposite thorax and apply resistance on the medial scapular border in the direction of the humerus. For scapular down rotation during adduction, again stabilize the opposite scapula and apply resistance in the inferior angle of scapula in the lateral apical direction. For testing of serratus anterior, patient starts by elevating the scapula off the table. Resistance is then applied at proximal and distal humerus. Alternatively, a standing modified push-up could be performed. For scapular adduction, testing the rhomboids, stabilize the opposite scapula on the thorax, and resistance is in the direction of the elbow. To test abduction, gravity minimized, notice the assistance is given against the gravity, not for the abduction movement. To test for forward flexion with a gravity minimized, again, notice the assistance is given to assist against gravity, not the flexion extension movement. For gravity minimized abduction and adduction, assist the arm against the forces of gravity. During gravity minimized testing for internal-external rotation, again support the forearm and the arm against gravity, not the motion. Testing the serratus anterior in a functional manner can be done standing at a table. Notice how the tendon can be located before the actual reflex test is performed by having the muscle contract. Ask the patient to look away from the arm to be tested or employ distractive strategies. Notice the distal location of the tapping for brachioradialis testing. Notice the appropriate amount of tissue indentation to elicit a response. Also notice the flicking motion of the reflex hammer. During test of sensation for light touch and sharp touch, notice the random pattern of the testing. Notice the minor but noticeable indentation of the tissue for sharp sensation testing.
We'll begin special tests by performing active range of motion. This time we're looking for asymmetries and signs of pain or weakness. We begin with the uninvolved left arm, noting the smooth scapulothoracic rhythm and full elevation. We then repeat on the involved right arm. Again, we see good scapulothoracic rhythm and full elevation. Next, our model is demonstrating an arc of pain between 70 and 100 degrees of abduction, both when elevating and lowering the arm. This is indicative of an impingement syndrome, usually of the supraspinatus tendon, biceps tendon, or subacromial bursa. Next, we see early scapular elevation, disrupting the normal scapulothoracic rhythm. This is most often due to rotator cuff weakness or possibly a partial rotator cuff tear. Next, we see inability to elevate the arm with marked scapular elevation. This is indicative of marked rotator cuff weakness and a likely tear. Here we see loss of active range of motion requiring testing of passive range. In this example, active range of motion is limited to 70 degrees, with passive range limited to 130 degrees. Next, we observe external rotation comparing side to side. Here we see a loss of right external rotation both actively and passively. Next we observe active internal rotation, noting in this example full rotation bilaterally, with the hand reaching to approximately T6. Here we see a loss of internal rotation, with the hand only reaching to the L2 area. A typical pattern for loss of shoulder motion is greatest loss of external rotation, followed by abduction, then flexion, with internal rotation nearly full. This is referred to as a capsular pattern of motion loss. In throwing athletes, however, the pattern is often reversed. Here we see increased external rotation with loss of internal rotation. This will often be seen in pitchers and tennis players. Next we'll begin selective resisted motions designed to elicit pain due to shoulder tendinitis. The first test is for the supraspinatus, sometimes referred to as the empty the can test. The arm is internally rotated while motion is isometrically resisted at 30 degrees of elevation in the scapular plane. A normal response is strong, pain-free resistance. Here we see good strength but pain, suggesting irritation of the supraspinatus, but not likely a tear. Next we observe pain and weakness, suggesting more extensive irritation and possible tearing of the tendon. Our next test is for external rotation, testing the integrity of the infraspinatus tendon. Again, the normal response is strong, pain-free resistance. A strong but painful response is suggestive of mild to moderate irritation of the infraspinatus, with pain and giving way suggesting more extensive irritation and possibly a tear. Next we can test internal rotation for the subscapularis. The same responses of strong and pain-free, strong and painful, or weak and painful are recorded. Here we're testing the biceps tendon by resisting elbow flexion and forearm supination, again noting pain and weakness. This resisted motion can also be performed with straight elbow, forearm supination, and shoulder flexion to 90 degrees, and is known as the Speeds test. Pain and/or weakness with either test suggests biceps tendinitis. The next test is the apprehension sign. Here we're testing for anterior shoulder instability by passively combining motions of abduction and external rotation. A positive sign is apprehension, or a sensation that the joint is giving out. Pain in and of itself is not a positive sign. The apprehension sign can be augmented by using an anterior shear force in addition to the combined motions of abduction and external rotation. Again, a feeling of instability is the positive sign, not pain. If the test is positive, then a gentle posterior shear will relieve the apprehension. This is known as the relocation sign. Next is the drop arm test for rotator cuff tear, particularly a tear of the supraspinatus. Even with a tear, patients will often be able to elevate to 90 degrees, but will be unable to hold the arm when even slight downward pressure is exerted. If the arm drops to their side, the test is positive. Next is the Hornblower Sign, testing for tear of the infraspinatus. Patients raise their hands to their mouth and lift their elbow as if blowing a horn. If the infraspinatus is torn, the arm on that side will drop into internal rotation. The infraspinatus can also be tested by seeing if patients can hold their arm against the force of gravity, pulling it into internal rotation. If the arm drops into internal rotation, the external rotators are weak. Here we see the liftoff sign, testing the strength and integrity of the subscapularis. If patients cannot lift their arm off their back, the subscapularis is likely torn. Next is the active compression test of O'Brien, looking for slap tears of the superior labrum. This is a two-part test, first resisting shoulder flexion with the forearm pronated, i.e. thumb down. Pain and/or clicking with this test suggests a torn superior labrum. The test is then repeated with the forearm in neutral, i.e. thumb up. This time there should be no pain. Next, we're repeating the apprehension sign, but this time in supine, where it is known as the crank test. This tests for both anterior joint laxity and anterior labrum problems. Apprehension and/or clicking are positive tests. Another labrum test is the Clunk Test. With the patient supine, abduct the arm to about 160 degrees and lift up on the arm, producing an anterior shear. Pain and click or clunking sensation suggest anterior labrum tear. Finally, we have palpation. These tests come last in a musculoskeletal evaluation, although on-field assessment of athletic injuries might require palpation for deformity immediately. First, we're palpating the supraspinatus tendon by internally rotating the humerus and placing it behind the patient's back. The supraspinatus is then palpated just anterior and inferior to the acromion. Next, we can palpate the infraspinatus by flexing, adducting, and externally rotating the patient's arm. The infraspinatus is palpated below the posterior aspect of the acromion process. Finally, the long head of the biceps can be palpated between the greater and lesser tuberosities of the humerus. It can be palpated along the course of the bicipital groove and up to the acromion when the humerus is extended.